So, very important, issue which we face nowadays in our practice, especially is the flood of patients with NAFLD, or what we call as now as MAFLD. So the difference between the two terminologies, that is NAFLD and MAFLD. NAFLD actually means hepatic steatosis diagnosed by imaging or histology, whereas metabolically associated fatty liver disease, which could be imaging, biochemistry or histology. There are mandatory exclusion criteria for NAFLD where non-alcoholic, that is alcohol intake less than 30 or less than 20 in women is permissible. Viral hepatitis has to be excluded and other etiologies of chronic liver disease has to be excluded. Whereas MAFLD, these may not be excluded, but obviously there has to be metabolic dysfunction like type 2 diabetes, overweight or obesity. And so that's mandatorily required. Metabolic dysfunction, combination with other liver disease can be there compared to NAFLD. And again, independent from alcohol intake, again something which is different from NAFLD, and no requirement for liver biopsy, which is often sought for diagnosis of NASH. So this is simple to diagnose, easy to diagnose, and probably easy to treat as well. So we do not require mandatorily to exclude the viral hepatitis, and especially the stringent requirement to rule out alcohol, especially the alcohol intake, the quantity of alcohol intake as well. But if we want to know the magnitude of the problem, whether we call it MAFLD or NAFLD, about 70 to 80% of subjects have NAFLD, which we also found way back in 2007, and about 28% have fibrosis, clinically relevant fibrosis, which is much higher in our population, almost double again. Very importantly, diabetes increases the progression of liver-related outcomes, whether it is NASH, whether it is cirrhosis or hepatocellular carcinoma, that is nearly double when there is a background of diabetes. So NAFLD or MAFLD with diabetes is a deadly combination. So we have found that most of our patients have BMI less than 30, the mean BMI was 24 and the waist circumference was 91. Most patients have normal liver enzymes as well. So the liver enzymes cutoffs should be lower, that is what we had found we had reported quite some time back as well. And if we look at the AAC guidelines, the ACE guidelines which are there it is recommended to screen for MAFLD in all patients with diabetes or pre-diabetes, with obesity, or if their liver enzyme, especially the ALT, is more than 30. Again, the two important aspects with regards to treatment is one, prevention of cardiovascular disease. Just like CKD, the major cause of mortality in patients having MAFLD with diabetes is cardiovascular disease, and again, the prevention of progression to cirrhosis. So basically, the management remains management of obesity, diabetes, hypertension, and dyslipidemia. Very important is to categorize the risk in terms of the fibrosis, because fibrosis is associated with cardiovascular disease. Fibrosis is associated with progression to cirrhosis as well as hepatocellular carcinoma. And one thing which is something very concerning about NAFLD is that it can progress directly to hepatocellular carcinoma bypassing cirrhosis. So that is also something which is very important to recognize. So in the FIB4, which is very easy to calculate with AST, ALT and a platelet count. So if the FIB4 is less than 1.3, so it's low risk. If it is between 1.3 to 2.67, it is intermediate risk, and more than 2.67 it is high risk. There are however two caveats. More than 65 years probably we need to have a higher cutoff. Again, it is less validated in less than 35 years. Again, all these tests are more for ruling out this fibrosis rather than to rule in. So that is something important. Once it is indeterminate or in the high risk categories, we need to do a liver stiffness measurement with elastography. Now it's again quite commonly available. If the LSM is less than 8, again it is low risk, it can be managed by any physician with regards to focus on obesity and cardiovascular risk management. If it is indeterminate between 8 to 12, it again requires further evaluation and specific therapy, especially if it is more than 12, there is a high risk of progression to cirrhosis, and this is more common. The progression is more common in patients who have background of diabetes with obesity, if the age is more than 50 years, if there are several other metabolic risk factors as well. If we look at the ADA guidelines, again, the FIB-4 is meant, it has been advised to calculate the FIB-4 even in patients with normal liver enzymes. And again, as we said, then we determine the high risk, low risk and intermediate risk. Especially for low risk, we can repeat the FIB-4 after 2 to 3 years. For indeterminate or high risk, we need to go for the fibroscan, and then we categorize the risk whether it is high risk and low risk. In type 1 diabetes, it is not mandatory to do FIB-4 in all patients, but we need to do it if the patients are obese or develop metabolic syndrome or have the ALT more than 30 or develop a steatosis or imaging. There we need to again evaluate for NAFLD or NASH or MFLD even in patients with type 1 diabetes. The problem with regards to diabetes management is there are limited pharmacodynamic studies in liver disease across the board. There are limited data available with regards to efficacy of antidiabetic therapy, the safety of antidiabetic therapy. Again, when we are looking into antidiabetic agents, we have a major advantage. There are several antidiabetic agents, anti-hyperglycemic agents, which have benefit in terms of NASH. So when we are looking into efficacy in NASH, there are two things. One is the NASH or the inflammation resolution without worsening of fibrosis. If you look at the clinical trials, they will be reporting two important things. Where there is inflammation or NASH resolution without any worsening of fibrosis, or where there is improvement in fibrosis without any worsening of inflammation or steatohepatitis. So these are two important aspects whenever you look into a study reporting NASH outcomes. This is most probably the gist or summary of my talk. The glucose lowering medications which we have at our disposal. Metformin in biopsy and imaging proven NAFLD improves AST/ALT and liver fat, but has no effect on liver fibrosis or on NASH, that is inflammation. DPP-4 inhibitors similar to metformin has no effect on NASH or fibrosis, may improve liver fat marginally or AST/ALT. Again, if we have the SGLT2 inhibitors in biopsy in patients with NAFLD, there is improvement in AST/ALT, liver fat, but again the NASH resolution is unknown and liver fibrosis effect again is unknown. So again the data is mainly with regard to liver fat content reduction. Now coming to pioglitazone, in biopsy proven NAFLD with diabetes and non-diabetes as well, there is improvement in liver fat, AST/ALT. Here it has been shown to improve NASH, steatohepatitis or inflammation. And the meta-analysis also has shown improvement with regards to progression of fibrosis. So one of the drugs showing some benefit with regards to progression of fibrosis. Next comes the GLP-1 group of drugs, where apart from reduction in hepatic fat content, there is now data with regards to NASH resolution and probably some signal of fibrosis improvement as well, but mainly it is with regards to NASH resolution. Again, this paper was published last year. So the tirzepatide, which is a GLP-1 and GIP agonist, had only benefit shown in liver fat, but now the data, there is a new publication with tirzepatide as well as the retatrutide, which is a triple agonist. Again, it was mainly with liver fat content. So, if you look at the American Liver Association guidelines, vitamin E, in mainly the evidence in non-diabetic patients, not in diabetes, Pioglitazone has benefit with regards to NASH resolution, fibrosis benefit, CV risk, and CV outcomes. But heart failure, fractures are important concerns as well. Liraglutide mainly for NASH without cirrhosis, mainly in NASH improvement and cardiovascular risk improvement has been there. With semaglutide, there is benefit with regards to NASH resolution, cardiovascular, and the recent flow trial has also shown the renal benefit. With regards to tirzepatide, we have the data which I will be showing has benefit in terms of NASH resolution in diabetes and weight management, and also possible benefit with regards to fibrosis. The Flozins main benefit is with regards to, apart from cardiorenal outcome improvement, is mainly with hepatic fat reduction, that is steatosis improvement. Now the potential mechanisms are almost all similar. The weight loss inducing medications, apart from weight loss, decreases inflammation and also the free fatty acid plaques, as well as the gluconeogenesis, as well as insulin resistance. So whether it is the GLP-1, the pioglitazone, then in pioglitazone you have body fat redistribution and also the multiple agonists. But very important to realize that even with the weight loss, even with bariatric surgery, there was improvement in fibrosis, about 40%. But that was probably the cap with regard to improvement in fibrosis. So even weight loss has to some extent has an effect with regard to fibrosis, but not beyond a limit as well. So if you look at diabetes management in NAFLD, this is probably best reiterated with the AAC guidelines. If in low risk, again we should be looking at cardiorenal outcomes. If it is cardiorenal, we will be choosing a GLP and SGLT2, and also choosing agents which have specific benefits in NASH as well. The targets HbA1c should be less than 6.5 or 7 as per the patient profile. When we are looking in low risk patients, the pioglitazone, GLP and SGLT2 can be used, whereas in intermediate and high risk, the GLP-1 and pioglitazone are preferred because they have evidence with regards to NASH and probably some benefit even with fibrosis progression. With regards to metformin, sulfonylurea, DPP-4 and insulin, the evidence is there with glycemic control, but they do not have specific benefit with regards to NASH or fibrosis progression. Now, in high-risk patients, especially in established chronic liver disease, most patients, especially those who are decompensated, we will be using insulin in most patients. And though there is some early data with regards to use of GLP-1, you see the different guidelines, whether it is the American liver disease guidelines, the ADA or the AAC, the recent ADA-AAC, most would recommend again the GLP and the pioglitazone. GLP-1 may be preferred in patients who are obese. Now, with regards to weight management, again, apart from lifestyle, which include both diet as well as exercise and calorie restriction, we again have the GLP or the GLP and the GIP or the triple agonist as well. Then bariatric surgery remains an important option. Again, weight loss, especially it has been seen the higher the weight loss, greater the benefit. 5% weight loss can improve inflammation, 7% can improve NASH, 10% weight loss can improve fibrosis. But the problem is with regards to sustainability of weight loss, where it is about less than 10% as well. With bariatric surgery, there can be resolution of NASH in almost 80% and fibrosis in about 50 to 70%. So bariatric surgery in severely obese can be considered when especially the BMI is more than 27, and only it should be very carefully done in compensated cirrhosis, definitely not in decompensated cirrhosis. Now looking into metformin, they do improve the liver enzymes and hepatic fat, but they have no evidence with regards to NASH or liver fibrosis. But one benefit is there, that is with regards to less hepatocellular carcinoma mortality, that is there with metformin use. With regards to SU, DPP-4, glinides and acarbose, they can be used for glycemic control, but they do not have any benefit or any study to show benefit in terms of histology. Insulin is again preferred in patients with decompensated liver disease, though there are studies now with semaglutide in compensated cirrhosis as well. Now, if you look at NASH resolution, the highest benefit in terms of anti-diabetic agents were semaglutide, then pioglitazone, then liraglutide. As we can see, as pioglitazone and the GLP-1 are approved as well. You look at dulaglutide, the main evidence is not with regards to NASH resolution, the evidence is with regards to ALT, AST normalization. The first of the GLP-1 showing NASH benefit and delayed progression to fibrosis was liraglutide in a small study. We have now liraglutide, which will be cheaper version, which we will be able to use. We have the semaglutide, where 62% patients had type 2 diabetes with NASH, and their injectable semaglutide showed almost 55 to 60% reduction in NASH. So that is very, very important. And again, the progression of fibrosis was delayed by about 20 percentage point. So some benefit with regards to early benefit with regards to progression of fibrosis, and this may be because of weight loss, because of decrease in insulin resistance, because of decrease in lipogenesis, as well as inflammation as well. Now coming to the dual agonist, tirzepatide, GLP and GIP agonist, you can see the HbA1c reduction with these molecules is more than 2%. The weight loss is more than 10 to 12 kg. So significant benefit. And there, this year, the publication which came in was that there in 50 to 60% there was resolution of NASH with use of this dual agonist. So that is something we need to we can look forward to, apart from very good glycemic control and weight loss. Very important, one fibrosis stage improved by about 50% of subjects. So again, a significant benefit even with regards to fibrosis progression. So in patients with NASH and fibrosis, moderate to severe, tirzepatide is a molecule which is for the future, for the resolution of NASH, and also may have some effect with regards to worsening of fibrosis. Again, survodutide, which is a glucagon receptor as well as GLP-1 receptor agonist, showing benefit in terms of NASH resolution, and again, early benefit with regards to fibrosis. Now we also have the triple agonists as well, the retatrutide, showing about 20% weight loss, almost as good as bariatric surgery, and there is also significant reduction in liver fat as well, but the data on NASH is still not there. Now looking into our old molecule which we have at our disposal, which is now pretty cheap, that is pioglitazone, which was originally used in pre-diabetes or diabetes. In this paper, there was about 58% resolution of NASH with a high dose of pioglitazone, which is about 45 mg. But there was this pioglitazone study in Taiwanese population with 30 mg showing similar benefit. Now the ADA 2024 guidelines is that pioglitazone is effective to treat NASH, may slow fibrosis progression and decrease cardiovascular disease, and the meta-analysis showing benefit with regards to fibrosis. Very important, we see prescriptions of vitamin E with pioglitazone in diabetes patients. There is no evidence to suggest that combining vitamin E with pioglitazone provides additional benefit. So, no point in using vitamin E in diabetes patients with NASH. Again, if we can use a lower dose and combine with SGLT2 or GLP-1, the side effects can be mitigated. As has been shown as here, you can see with a lower dose of pioglitazone, only 1% weight loss, and when we are combining, especially in this study with semaglutide sustained 2, there was actually weight loss when it was combined with semaglutide, and similarly in the EMPA-REG extension study, there was a weight loss when combining pioglitazone with empagliflozin. So if you can combine these two group of medications or three as well, there can be significant additional benefits as well. And you can look at SGLT2 inhibitors in terms of decreasing liver fat, some evidence of liver stiffness and improvement in histology as well, and advanced fibrosis scores. Compared to DP4 inhibitor, they decrease NAFLD as well as hepatocellular carcinoma and decrease death in patients with liver disease and CLD as well. With DP4 inhibitors, probably the best evidence at all stages of liver disease, their dose requirement adjustment is not required with linagliptin, which can be used in mild, moderate and severe impairment. Sita and Saxa can be used in mild and moderate impairment, because linagliptin is mainly excreted unchanged in bile. And again, even in late stages of CLD, there is no excess exposure to linagliptin and their glycemic control efficacy remains similar. Now, looking at our own Indian molecule, the saroglitazar, which is a dual PPAR alpha gamma agonist, there is improvement in NAS score as well as early evidence showing benefit in terms of elastography. So, it has been approved in patients with NAFLD. So, again, there are lots of prescriptions we see with use of ursodeoxycholic acid. There is no evidence with regards to ursodeoxycholic acid or silymarin in patients with NASH. Statin use has to be continued even in patients with compensated liver disease as well. So in conclusion, current guidelines, we need to pick the NASH patients early to prevent the progression to cirrhosis or other cardiovascular disease as well. Fifth point is a good screening tool, followed by the imaging, that is elastography. We need to, especially in established NASH, we need to treat with pioglitazone or GLP-1. If there is cardiovascular disease, we need to use SGLT2 inhibitors as well. But SGLT2 inhibitors doesn't have a significant impact on steatohepatitis. The pioglitazone and GLP-1 group of drugs, especially in GLP-1, the evidence is there with liraglutide and semaglutide. And again, we can consider using agents, especially with cardiovascular benefits, because majority of patients with NASH will die of cardiovascular disease. So again, pioglitazone, liraglutide, semaglutide all have cardiovascular benefit as well. Saroglitazar may be considered, but again the fibrosis data is still not there. Again, you must remember that there is no role of vitamin E, at least in diabetes patients with NAFLD. Probably the future looks pretty bright. We have one approved agent as well, which is a thyroid hormone analog for treatment of NASH, though it's not an antidiabetic agent. Again, we have the dual agonists, GLP and GIP, the triple agonists, even some of them being oral, which are now approved elsewhere outside India, and those agents are showing very good data in terms of NASH resolution, in terms of fibrosis progression and weight loss and glycemic control. So probably combining, just like what we used to do, what we are doing now in heart failure, what we are doing now in CKD, probably in future we will have 2 or 3 pillars of NASH management, where apart from lifestyle, that is weight loss, as well as good glycemic control, cardiovascular prevention, we will have agents like pioglitazone, the SGLT2 inhibitors, as well as the GLP or the GLP-GIP combinations to prevent the progression of NASH to cirrhosis and decompensated cirrhosis. Thank you very much. Thank you for a patient hearing.
Thank you, sir. Any questions?